So I alluded to this before about patient expectations, and there's some really interesting phenomenon going on, even on the reimbursement side, that patient satisfaction has now become the most important quality outcome metric that will, and now it's going to affect our reimbursement. And it's directly linked to the patient's preoperative expectations. So that means that the onus is generally on us in terms of managing our patients and how they do postoperatively. That's the move. That's the advanced sign.
Thank you.
Okay, tap. Just go past this, please. Go past that, please. So that was that patient I showed you before. There's her radiographs. That's the one who had the chronic pain. Next slide. The other side, so remember she had bilateral cuff pathology. Now I'll show you what she was living with. Next one. Advance one, see if the MRIs go. Go back. Can you tap the left one, please? This is, yeah, and tap the other one, please. So this is just to give you a sense of what she's living with, okay? Pretty amazing when you think about it. I mean, she's been relatively asymptomatic and she has a fall and outstretched arms, but she's got basically the highest grade Guttilier changes you can find and basically nothing there in the superinfraspinatus. So what are the options for that patient? And I've already alluded to this, that first of all, if you go to the clinical practice guidelines that the Academy has put out based upon the available evidence at that time, one of the conclusions was that non-surgical treatment is an option for patients with chronic symptomatic full-thickness tears. And I told you about that Moon study where 85% of them remained surgery-free as long as they believed that physical therapy would help. And it had nothing to do with the tear size, the chronicity, the age of the patient, all those other things you think would matter. It had nothing to do with that. So this patient, we did an injection, as I told you, and she did well. Now, one of the things that comes up a lot is, well, look, that's fine. I'll take the injection, I'll do the physical therapy, but if I ignore this, will this tear get bigger? What happens if I do nothing? And the summary of all the data right now is that 20 to 50% of them will progress over time. Progression will occur without increasing symptoms, and if they represent to you with pain, it's more likely that at that time they'll actually have a larger tear. The other two factors that come out in terms of progression are age over 60 and greater than 18 months of symptoms associated with, if they represent, is associated with tear progression. So this is a patient, can you go back please? Go back twice and forward once. Okay, good. So this is a patient who's 52, who has a right shoulder work-related injury about a year and a half prior. He had an arthroscopic cuff repair for a small full-thickness defect. He had a revision 4 months later after a fall, and then he was referred 8 months post-op. So he's already had 2 surgeries, and he also now complains of acute biceps rupture with weakness. These are his x-rays, nothing really remarkable. His head's well centered, no arthritis. These are just a couple of snapshots of his MRI. Not that bad, but the point is he's already had 2 repairs within 1 year. He had a relatively innocuous stumble and results in an alleged re-tear. Maybe it was a failure to heal. We'll never know. The bottom line is a repeat MRI 3 months after his first repair showed a re-tear. So this is what was seen arthroscopically. So is it the definition of insanity? You just repeat the same thing again? Do we, done by a good surgeon, good technique, or do we start thinking outside the box, what are we going to do next? So this is one, at least in my practice, as an alternative method to re-repair, is I'll use an extracellular matrix. So this is the perfect option in my mind for a patient like this, if you can get the next video too. And I think that we all have our different algorithms of when we're going to pull in a matrix. This is not an SCR. This is one that has a cuff that can be incorporated and repaired. You can get it down to the bone, but he just continues to fail. So what we're trying to do, I think, is some permanent conformational change that's a biomechanical thing as well as maybe something biologic. So it's a lot like a hem reinforcement. The tissue itself is obviously not holding up. Most of the times you get in there, the anchors are still in the bone, but the sutures have pulled away from the tendon. So that means there's something wrong with the tendon that's just not going to hold a suture. And to repeat it again doesn't make a whole lot of sense. So at least my own treatment algorithm is that's the time that I'll use a patch as an augmentation, as an onlay on top of a traditional repair. Next slide. There are pretty good outcomes when it comes to extension and interposition. Most of it's level 4. But the bottom line is compared to historical controls and re-tear rates, we're doing 80% or better in terms of MRI follow-up with augmentation or interposition. Another example. 55-year-old right shoulder pain, prior massive rotator cuff repair, never got better. He's continued to complain of pain and weakness, unresponsive to conservative care. He's got active motion loss and preserved passive motion, and he's weak. You can see his evidence of his previous repair. This one's different than the last because nobody's home, right? Look at the supraspinatus fossa. He's got a little bit of proximal migration, not much in the way of arthritis. Some are probably thinking maybe reverse is an option. What are the other options for a guy like this? This is where he is at arthroscopy. What would you do? This is, in my opinion, the perfect one for an SCR. He's the right age. He's got the right expectations. He's looking for pain relief. Next slide. Go next slide. You've heard enough about this. I'll just show you basically what we did. So you can see in this case, the anchor pulled out. Not that common. Most of the time you get in, the anchors are still in bone, and but you get chronic retracted tissue. And this is one where there really is no ability to get that tendon edge back out to the bone, right? So we do exactly what you saw with Tony's case. You can see how complicated this case is. It's like a game of chess, basically, to get this back. There's a lot of steps that you got to plan ahead for, have a good staff, and try to basically do this a step-by-step approach. And the procedure's not that difficult, but there are a number of pitfalls. And having good representation in the operating room, having all your anchors available, be prepared for ankle pullout, all of these things can happen. And I think the toughest part of this is just suture management and just taking your time with each particular step. It's a very manageable operation, and I would encourage all of you to try this in the lab first, just to get your steps down before you take it to the operating room. I don't think watching a video or watching someone else do it is enough. And just give you another one. This is a 70-year-old male. He began having right shoulder pain a few years prior. He had a cortisone injection and physical therapy provided some relief. He recently fell and got another cortisone injection. He's continued to have 3 out of 10 pain in his right shoulder. Next slide. Again, you see significant atrophy. Next slide. This is what we got at time for pathology. Real, very atrophied and so forth. What are you going to do with this? So this is something probably many of you not heard of. It's a subject of a clinical trial. This is a massive irreparable cuff tear. What are the options? You can do an SCR. This is something that will be on the horizon, I think, once they get through the FDA process. The study is almost completely enrolled, and it's a subacromial balloon. And it's basically a spacer that goes into the joint. It is not permanent. It resorbs over time. So you put the balloon in, you fill it with saline, and it basically serves as a spacer above the humeral head against the acromion. So the premise that some say is, well, does it form a pseudocapsule? Does it hold the shoulder down? What's really happening? My opinion is that this is serving as a temporary splint to press the proximal humerus so that they can more effectively rehabilitate the shoulder. And I think it's really nothing more than that. Because the balloon's going to go away. I don't think they're going to maintain their acromial humeral distance anymore. This is not indicated for patients with osteoarthritis, but it's indicated for patients who have an irreparable tear. So it's a really simple operation. It takes literally about 3 minutes to do. I imagine this is going to fall into the hands of the interventional radiologist and can be done in a suite. And it doesn't even have to be done in an operating room. But the clinical trial basically right now is a randomized study. Half get the balloon, half get a debridement, maybe a partial repair, but these are, quote, irreparable tears by the definition of you can't really get it back, there's chronic atrophy, and the subscap has to be intact. That's the inclusion criteria. So we've enrolled a number of patients in this trial, and I'll just give you an example. This is that same guy now. Can you turn the volume up? Not sure. All right, anyway, he says he has no pain. This is actually his 8-week visit. Okay. Show him the physical. Plain. Okay. Can you click on the right video? Just show his physical exam. So you saw what he had. Basically, he was unable to get his arm up above 90 degrees in the holding area at the time of his surgery. He says he had instantaneous pain relief after this. It's almost like remember those Parkinson videos you used to do when you show dopamine, you give them the medication, the guy's like staggering, and then you give the medicine, he's no longer staggering. I mean, it really is surprisingly remarkable. You know, I have no conflict in this. We're simply an investigational site, but I've been particularly surprised at how quickly these patients respond. And so I think this is the real thing, and it's going to be on the radar not too distant future once they get through the final FDA throws. Another one. Can you turn it if volume is not working now? All right. So basically, it's a 58-year-old right-hand dominant male with right shoulder pain. He's had 3 dislocations after a fall 1 month prior. He can reduce his shoulder himself. He has a history of a rotator cuff repair 15 years prior. Rotator cuff tear 15 years prior that they treated non-operatively. So he has pain, dysfunction. He's really kind of sick and tired of living with this problem. So I'm showing you another extreme because you can take the same pathology and come up with a different solution for these patients. Go to next slide. Here's his physical exam. He's got limited range of motion. Some might call that pseudoparalysis. I don't know, Tony and Nick, we've been talking a lot about this. Tony, is this pseudoparalysis? You'd have to see the beginning of the slide, but basically he shrugs and he gets it up about 40 degrees. So he's got lag signs in adduction and lag signs in abduction, and he's painful. So some might argue if you'd inject him and get rid of his pain, maybe he'll be able to get his arm over his head. Is that really pseudoparalysis? But the take home with this guy is he's dislocating and he's sick of living with his problem. Next slide. These are his radiographs, not the most in the way of arthritis. Next slide. Here's his MRI. Again, nobody home. You can't really judge proximal migration on an MRI because they're sitting supine in the gantry and the shoulder's going to right up. So don't use the MRI to decide if he has arthropathy. But you know he's got a bad chronic cuff tear with lots of atrophy. Next slide. CT scan, because he's had these dislocations, so we're a bit concerned about his glenoid. And I think things checked out pretty well from a bony assessment. I've had patients like this where we've actually done a ladder J on and ignored their cuff tear, and they have a stable painless shoulder. So what are you going to do for this one? This is the last option I'm covering, and you're going to hear a whole talk on it, but I think in my practice, this is the one who falls in the category of reverse arthroplasty. So these are patients who can't get their arm up above 90. They have OA. They're irreparable anatomically and physiologically with advanced age. They may have escape. They typically have a reduced acromial-humeral interval, and they've often failed a previous repair. And I'll tell you this, he said he was off pain meds in 2 days. Pain was completely gone. You can look at his motion. His forward elevation is 160, external rotation of 45. He's still very weak in external rotation. And he would say he'd do it again, that it changed his life. Next slide. So some final thoughts. I think it's important to manage these patients' expectations, and again, it's now tied to our pocketbooks as it relates to patient satisfaction and outcomes. Non-operative treatment is still a viable option, as I've already discussed. Tears may progress, yet remain asymptomatic. That's important to know. Just because they get bigger doesn't mean that they will become symptomatic. And when the pain begins, however, it is often associated with tear progression, and they may have worse tissue quality. So that has to be part of the education for the patient. Bottom line is we need to individualize our treatment. Thank you.